Thank you, Mr. Chairman. I think we can all agree that comparative effectiveness research can be a useful resource for doctors and their patients, but it should not be used as a tool to limit or deny coverage of treatments. This bill creates an entire new federal regime to conduct CE research. Alarmingly, the bill has no restrictions on how the federal government can use this research. This is a dangerous open-door policy that will almost certainly lead to comparative effectiveness research being used to make coverage decisions. Here's what CE can teach us: what treatments are generally more effective than others, which procedures might work better for a particular disease than others, or which drugs have a bigger impact on treating one disease over another. But this is important. Comparative effectiveness research is about general average assumptions. It can't determine anything about an individual patient with a unique condition looking for a unique treatment. We cannot allow the federal government to use a calculator or a bureaucratic standard to get in the middle of patients and doctors. Here's some examples of how they do it in other government-run systems. A 23-year-old British woman was diagnosed with cervical cancer. She had asked for a pap smear 3 times and was denied by the National Institute for Clinical Excellence, their version of comparative effectiveness research, because it only provides service to women over the age of 25, and they do that for cost reasons, not because it's best for that patient or respects the doctor-patient relationship. A 36-year-old woman, oh, by the way, that woman did get cervical cancer at age 23. A 36-year-old Ontario woman was diagnosed with stage 4 colon cancer. Her doctor suggested a cancer treatment that targets cancer cells exclusively. Unfortunately, the Canadian government would not cover that drug on the claim that the treatment was unproven, even though that drug is a standard cancer treatment covered by insurance companies in the United States. A 46-year-old Montreal woman was denied access to the only cancer drug that would keep her alive as she battled a very tough form of colon cancer. The drug is a standard treatment in the United States, but Canada denied the treatment because it said, quote, "We wanted to see a more prolonged survival rate." The government made a life and death decision on that patient. And the reason they do it, it's because the only way that the government can control costs is by denying access or denying treatments. These are tragic stories. These patients deserve better, and I believe Americans deserve better, Mr. Chairman, and shouldn't be subjected to government rationing health care. My amendment is very simple. It would prohibit the federal government from using comparative effectiveness research to deny or ration health care. It's common sense protection that must be included in this bill. Only doctors and patients should be making the decisions about what treatments are best, not a government bureaucrat.